And hello, good morning, everyone. My name is Ángela Figuera. I am an adult hematologist. I work in the Hospital de la Princesa. This is our new bone marrow transplant unit, and mainly a transplanter. I was formed at the Fred Hutch Cancer Center in Seattle many years ago. And I am going to talk about hematopoietic stem cell transplant for very different diseases in adolescents and young adults. The problems of this age group have been talked many times in these talks, but there is not a net separation between adult and pediatric medicine. There is a net separation between adult and pediatric medicine. Traditionally, frontier is established at 18 years, at least in Spain. AYAs are outliers for both because they are in this group age that you don't know whether they're going to be in a pediatric or in an adult unit. There is an unclear distribution of pediatric and adult diseases. Pediatric hematologic neoplasias are under strict protocols, whereas adults are treated irregularly, makes them excellent candidates for transplant. Actually, being an adult hematologist, I'm really very glad when I have a young patient coming for transplant instead of a 65. They tolerate intensive conditioning very well. They usually don't have comorbidities. Usually they're not present. There is a very recent update on the SOROR HCT-CI index on them. And the only problem is that they have a 40% incidence of lung problems, which are very difficult to know why they are. Probably some of them smoke. Some of them have resisted previous infectious diseases. But toxic-related mortality is very low compared to older adults. And what it is very important, any donor is acceptable for this age group. They have 100% disponibility of donors, either if they are HLA identical siblings or unrelated donors. Haplo transplants are increasingly being used, or cord blood units. Allotransplants is always possible in this age group, or almost always. So it should be applied without hesitation when indicated, particularly for high-risk disease, because the patient is going to be cured for that. But there are several questions that are not answered, like if they need specific support for psychosocial and behavioral aspects. This aspect has been very important for this group. In fact, all this movement about AYAs is based on their specific needs for psychosocial and behavioral aspects. But the question now that we're talking about medical issues, are there any different indications, complications, or results in this age range? We don't know about that. And something that is really very important, long-term complications are a major trade-off of this type of therapy because it could lead to permanent organ damage, infertility and gonal damage. Chronic GVHD sequelae are terrible, and secular malignancies are almost horrible. So reviewing, I am a hematologist, I'm not an oncologist, so I will talk only about hematologic diseases. I will spare oncologic diseases because I know nothing of them. We are talking about these diseases like Philadelphia negative ALL, Philadelphia positive ALL, AML, and the two types of lymphomas. Regarding Philadelphia negative ALL, about 85 to 90% of children are cured, whereas only 30 to 50% of adults are cured nowadays. AYAs with pediatric protocols have raised their cure rate to 65, 75, almost reaching the results of children. Philadelphia positive ALL is more frequent in AYAs than in children, so they get more transplants, as we will see. AML is, in children offers a cure rate of about 60 to 65, whereas adults only to 30 to 55, but this includes all ages and includes frequent transplant. AYAs are short in the middle, like with 40 to 60% cure rate. Hodgkin's lymphoma, I won't talk very much because Isabel just recently gave an excellent talk. And non-Hodgkin's lymphoma has no different rates in AYAs, children or adults for the same type of lymphoma, although AYAs have different types of lymphoma than children and adults. I will talk also a little bit about other hematologic diseases because they have questions related to the stem cell transplant, like hemoglobinopathies, particularly sickle cell disease, and Fanconi anemia, which is a model of pre-neoplasia that is fascinating for all of us. There are differences, obvious differences between hematologic diseases in AYAs versus children's. Generally, they have worse neoplastic disease biology. They're more in favor of cytogenetics, particularly Philadelphia positive ALL is more frequent with increasing age, and MLL alterations is also more frequent. There are less favorable cytogenetics. For example, core binding factor leukemia is less frequent in adults than in children. There are also a lot of reports about higher toxicities from intensive treatment. Ayas have more diabetes, more obesity, more osteonecrosis and thrombosis. They have more infections. They have more frequent tumor lysis syndrome, and they have higher toxic-related mortality. And another issue is the lower access to health care, where in Spain we don't have that problem because we have universal coverage. But yes, they have less inclusion in chemo protocols, including stem cell transplants. This is the activity of transplant in Spain, as published by the National Organization for Transplants. We do almost 2,000, almost 3,000 transplants a year. This is the whole thing from 1994 to 2012. This is the rate in children. From the 2,700 transplants done in 2012, we have about 200 in children, but we don't have specific incidence for Ayas. We don't know how many transplants are done in the age group of adolescents and young adults. The main indication for transplant is acute leukemia, which is increasing as is reflected in these graphics. So I will talk now about different diseases subjected to hematopoietic stem cell transplant. Regarding ALL, which is the main indication for this age group, the most important trial for transplanters is this publication published by Goldstone in Blood in 2008. It's a combined study from multi-center study with thousands of patients. In fact, there were almost 2,000 patients. The majority of them had an age between, this is adult study, between 15 and 64 years. 1,646 were Philadelphia negative, and this analysis demonstrated that when you have a donor, the survival is a little better with intention to treat analysis for Philadelphia negative patients when they are transplanted versus non-transplanted, donor versus no donor. If you take the group with a standard risk, which include all of the patients younger than 35 years, the difference is even more. But there are several problems with the study. In a previous publication, they analyzed the age group differences, and they found that although the younger patients do better, the younger patients have a very bad results because they have 40%, which is suboptimal outcomes for Ayas in this trial. There's another publication done by Burke, which is the leader of the Minnesota stem cell transplant team, very recent one, in which they analyzed the older age group for pediatrics, and they found that the patients older than 13 have more toxic-related mortality. Excellent results. At the same time, there are excellent results in pediatric ALL chemo protocols for Ayas. So a stem cell transplant in first CR for standard risk ALL is really questioned lately. And it should probably only reserve for high-risk cytogenetics, specifically for Philadelphia positive ALL. There's a 3% incidence of Philadelphia positive ALL in patients younger than 18, but it raises to 20% in the group above 18 to 50, it raises with age. In children, the introduction of tyrosine kinase inhibitors coupled with chemotherapy questions the necessity for allo-STT for all Philadelphia positive patients, and lately the Children's Oncology Group and all groups are doing studies in which they're basing their indication on the presence of minimal residual disease positivity after consolidation. In our age group, in Ayas, probably it's the same, but they have a salvage rate less than children when they relapse. The allo-STT generally is still indicated in first CR, and more trials are needed to answer this question. This is so you have an idea, the number of transplants that have done by the Grupo Español de Trasplante de Médula Ósea in children in Spain. Is a slide that gave me Isabel Badel, who's the president of this group, so that you have an idea of how many transplants are done in children, specifically below the age 18. In Spain, from 1976 to 2013, almost 5,000 transplants. The majority of them are auto-transplants, half of them are auto-transplants, and the other half are allo-transplants. And in ALL, I asked her to give me this stratification by ages, and you can see that the patients older than 11 are doing a little worse than the younger patients. Now I will turn to AML. Chemo protocols are slightly different in children than in adults, but not very different. The only difference probably is that induction in children usually includes more than 3 drugs and consolidation more than 2 drugs. A stem cell transplant in first CR is only done for very high-risk disease, and all these chemo protocols have improved their results in children, but not so much in AYAs when they're applied to AYAs. AYAs in adults younger than 65 usually have protocols in which induction includes only 2 drugs, like the 3x7 protocol. Consolidation is usually based on high-dose RAC, frequently alone as the only drug. And stem cell transplant in first CR for high and intermediate disease is still done very much, although lately we're moving to doing transplants, at least for intermediate risk disease with minimal residual disease monitoring, as we have more molecular tools to follow these patients. Allo-HTT procedure is the same for children and adults. Retrospective studies in children in AYAs are equal, and there are no prospective studies. Now I'm going to show you 4 of these studies. This is a study in which there are 2 children protocols for AML with 1,600 children, and they try to analyze the group of AYAs between 16 and 20 in which these protocols were applied. Survival is the same for 2 age groups, but again, toxic mortality is greater in patients older than 16 with the children protocols. This is another type of study in which what they compare is the group of AYAs from 16 to 21 in which were treated with children protocols versus adult protocols. The difference in survival favors children protocols, but the difference may be due to age differences because in the group treated with children protocols, the patients were a little younger. And the mortality and the toxicity is greater with children protocols that are usually more intensive than with the adult protocols. This is another type of study in which the IBNTR and the National Marrow Donor Program with a lot of patients, 2,700 AYAs included in this study, tried to see whether with time the patients improved in their results and whether it was the same improvement in the children, in the AYAs, and in adults, because you all know that during the years we have improved our methods of stem cell transplant and our results based mainly on supportive care, use of antibiotics and everything. And they demonstrated that the AYAs group also improved the results with time. This is the improvement in children, this is the improvement in adults, and this is the improvement in AYAs. And in fact, this happened in HLA identical as well as in unrelated transplants, where the children didn't improve very much the results in this situation. And finally, this is another study in which the same Minnesota group, as I told you before, that analyzed the difference between children and adolescents in transplants for ALL, analyzed the same thing, and it was very recently published in transplants in patients with AML, comparing children younger than 15 years with AYAs with 15 to 30 years. And they certainly found that the disease-free survival for children is a little higher for first CR, second CR, or beyond, that in AYAs, where the numbers are lower, but there's no statistical difference between these two when they stratify for the different status of the disease. However, they found again an increased transplant-related mortality for AYAs, and particularly it was very, very astonishing that they found more chronic GVHD for AYAs than for children. Now, moving to another disease, which is Hodgkin's disease. Isabel talked so much about it that I will talk just a little bit. Mainly what is done is autotransplant for Hodgkin. The indications are primary resistant or progression, early relapse, or second relapse after conventional therapy for first relapse. The prognostic factors she already said very well. What is very important is the stage of disease and response to therapy, because the patients that are chemo-resistant disease go very badly. The results of the autologous transplant offers an overall survival that varies very much from 40 to 70%, and there are frequent relapses after autologous transplant. And what is more worrisome, there are a lot of late toxicities like AML and MDS and second cancers, as she already said. However, allotransplant for Hodgkin's is indicated in the 20 and 40% relapses after auto transplant, because as she said very well, there's no cure after you relapse after an autologous transplant. There is no cure with conventional therapy, although brentuximab and bendamustine may be an option. Disease-free survival after allotransplant for Hodgkin's, for advanced Hodgkin's, is not very much. It's 25 to 50, but it's something, whereas on the other side there's 0. And there's a demonstrated GVL effect demonstrated by the presence of chronic GVH and the use of DLI after transplant increases the results. However, toxic-related mortality was really very high in earlier myeloablative conditioning in the 90s, picking up to 60%, but has decreased to almost 10 to 20% with reduced intensity regimens lately based on fludarabine. So what we're doing now is restricting indication upon prognostic factors, particularly chemosensitivity pre-transplant, and about the procedure, trying to use, as I said, reduced intensity regimens with fludarabine, and any donor is fine, like HLA identical siblings, unrelated donors. There's some question about cord blood donors for Hodgkin's disease, because apparently the results are a little worse, as the French study demonstrated lately. And what is very exciting is that lately haploidentical transplants are going to be also a very good result. This is a review published by Ana Sureda and Alexander Claviez in the bone marrow transplant in 2008. There's pooled data from many different studies for auto-transplant, usually in first relapse. We have, this is for the AYA group specifically, we have really good results, but it's more important is to know that chemosensitivity is essential to subject these patients to transplant, because the patients that are chemo-resistant will all die, whereas the patients that are chemosensitive have a chance of cure. Moving to the allotransplant, which is also reviewed, allotransplants are done a little later. The results are worse. And it's very important to see that the patients that were subjected to myeloablative transplants had a very high toxic-related mortality that has reduced almost to half with reduced intensity conditionings. And this is the latest study, was published also by Alexander Claviez and Ana Sureda in Blood in 2009 regarding transplants, allogeneic hematopoietic transplants in children and adolescents specifically. And what they compare in 91 patients was the difference between having a myeloablative transplant and a reduced intensity transplant. And surprisingly, they found that the toxic-related mortality was the same in this study, which is a randomized study. Yes. The relapse rate is a little bigger in reduced intensity transplant, and that makes that the progression-free survival is better in the myeloablative transplant, but finally, the overall survival is the same. And what they found, which is very important to select patients for this type of treatment, is that the patients that were chemosensitive pre-transplant and had good performance before the transplant had an excellent survival with an excellent plateau and a very high cure rate. And finally, this is a study published by the Fred Hutch and the Baltimore group combined, using the latest thing in allotransplant, which is the use of haploidentical donors using cyclophosphamide post-transplant on day 2 and 3 in a very high dose. All of them were young adults because they had between 33, 28, and 32 for the different groups, HLA identical, unrelated, and haplo, and see how the haploidentical transplants do even better for advanced Hodgkin's compared to HLA match or unrelated transplants. This is a very fascinating question because every patient has an haploidentical donor, and if we confirm that the results are true, we can move to allotransplant for haploidentical donors very easily. I will talk just a few words about stem cell disease. It's not a cancer disease, but it has a very important problem because stem cell disease, sickle cell disease for patients homozygous is a very horrible disease, and more than 90% of the patients will be cured with transplant. However, transplant rate is very low and very late, and that probably worried a lot in the United States, where this disease is very frequent. Because the transplant is unavailable for most patients due to socioeconomic problems, and there's a lot of fear of complications because this is not a cancer disease. So they're very fearful about transplant-related mortality or late effects. However, the results, as published and said by Elaine Gluckman in the Educational Affairs in 2030, are excellent for transplant. So these patients should be transplanted, and every effort should be done to reduce their late effects. And also, it's very important to talk about Fanconi's anemia, because Fanconi, for us, is a pre-neoplastic disease, which is very worrisome. Stem cell therapy, transplant is the only cure for FA. The overall survival nowadays is between 70 and 80%, with a little worse results with alternative donors, but they're improving. Results are also complicated by high toxic-related mortality, acute and chronic graft-versus-host disease, but which is more worrisome is the second neoplasia problem. We're curing these patients for aplastic anemia, and then we're making them living longer, and finally they have a second neoplasia. And it's a very excellent model and an excellent, let's say, experimental field in which we can see what maneuvers we're doing to create this second neoplasia, increase risk, and see whether the transplant increases this risk. This is the last paper published by Regis Pefol de la Tour in the Blood in 2013, in which you can see how the Fanconi results have improved so much that there is almost 80% survival, but see how terrible is the cure of second neoplasias. In survivors of more than 1 year, the incidence goes to 21% at 15 years, which is terrible. Risk factors for second neoplasia are older age at transplant, clonal evolution before the transplant, let's say the patients with aplastic anemia that are getting into MDS or AML, the use of peripheral blood instead of bone marrow, and the presence of chronic GVH, which is one of our horse field. Now I'm talking about what worries all of us, which is long-term effects after transplant. I have reviewed several diseases that are cured by transplant. Most of the transplant that we're doing are doing in diseases that otherwise will be lethal and will kill the patient, but we're curing a lot of patients, and we have to worry now about long-term effects. I've been working at the bone marrow transplant unit of Hospital de la Princesa 30 years now. I lead the long-term effect and the consult of transplant, and I have almost 450 survivors or 500 survivors that come all the time to the consult, so I know this very well. Long-term survivors of more than 2 years after transplant, the majority of them, more than 80%, will survive long-term and are cured because the relapse rate decreases very much after that time. Recovery from transplant is a very long process. There are physical sequelae like chronic GVHD, organ damage or infertility, decreased physical performance. There are a lot of publications on these issues. Psychological adjustments, psychiatric problems, cognitive and memory problems, particularly in children or ayas, sexual problems, full social and work returns is very difficult, and the use of secondary malignancies, which is a terrible trade-off. Several retrospective studies have demonstrated more late effects and general impact of HCT compared to chemotherapy survivors in children, but as I said, stem cell transplant is not elected by these people. They have to do that because otherwise they will die. That's why we have to go to that. In AYAs, this aspect should be specially considered because informed consent for them is very important, and we heard yesterday how the girls that talked here were very upset about not being informed about late effects. As you can see, it's very difficult to inform a 16-year-old or a 15-year-old about whether they're going to be infertile, whether they're going to have breast cancer later on when they are menaced by a disease that is killing their life in that moment. So that is a very difficult thing, but should be done. And post-transplant, we have to follow these patients very carefully, and the burden that is increasing the transplant teams is terrible because, as I said, 450 patients talking and calling you all the time for every problem they have. It's a very big burden for just one person or a team of 2 or 3 people as we are regularly. So this problem of late complications of transplant has been reviewed lately, and guidelines have appeared in the 2012. This is the terrible and long list of late effects. Most of them are more frequent in allos than in autos, and more than 80% of the patients have at least one of these late effects after allotransplant, especially, like infections, all of them related to chronic GVH, ocular Zika and cataracts. We are seeing cataracts in 35, 40-year-old people that have to have surgery. Oral Zika and caries, they lose their teeth. Pulmonary complications are also very frequent. You know, we have some patients, very young patients, that have changed their cancer disease for bronchopulmonary chronic problem, cardiovascular problems are very frequent, hepatic hemosiderosis, hepatitis B and C, renal problems, bone problems, endocrine problems, psychosocial problems, which are very important, infertility, and second cancers. This is the guidelines, very short said, that have appeared. There are at least 3 publications on guidelines for follow-up of survivors. What do we have to do for all these things? Mainly what we have to do is take care of them. And the problem we have, as I said, is that the family doctors and general doctors don't know these problems. And I very frequently have patients that, for example, with 35 years old, they have a chest pain, they go to the family doctors and they don't think they have an infarct, and they really have an infarct. So we should have to do some kind of a spread of the information to family care doctors and general practitioners, that they know that a transplant is a very fragile patient that has to be followed very, very carefully. And regarding the issue of solid cancers after transplant, we have seen the tremendous risk of cancer for Fanconi's anemia, but this is the pooled data that has been published by Rizzo in Blood in 2009 for 25,000 patients, pulling the data from the Fred Hutch and the National Marrow and the IBMTR, for 28,000 patients. And the incidence, the cumulative incidence is 3.3 at 20 years, and the ratio, the ER ratio, was about 6%, 6 times more solid cancers after transplant for all these enormous population of patients that are being followed at 20 years. The risk factors, as always, are usually younger age at transplant, because these younger people are more fragile, their tissues are being developed yet, and they live longer. And, for non-squamous cell cancer, younger age, less than 30 years, poses a 10 times more risk than for patients older than 30 years. The use of radiation in the transplant or any time before the transplant increases very much the risk, as well as the time elapsed from the transplant. For squamous cell cancer, basically oral cavity cancer or pulmonary cancer, male sex is very important, and the presence of chronic GVH is very important, because chronic GVH produces Zika, and the lungs are dry, the mouth is dry, and that creates a very higher risk for squamous carcinoma. And the question of breast cancer is also has been seen not only in Hodgkin's, as Isabel said, but also in every patient transplanted in an effort by the Fred Hutch and the EBMT Working Party. They have published a recent study in which they included 3,300 females, in which followed after 5 years after the transplant, and they found 52 breast cancers at 12.5 years, with a cumulative incidence of 11%, that raises to 17% when the TBI is used in the conditioning. So what should we do with second malignancies after transplant? They're increasing screening recommendations, as Isabel also said for Hodgkin's. We have to do mammographies, a study of the vaginal pap smear, colorectal, we should do colonoscopy, we should do skin exams for melanoma, as later will be talked. We should look for pulmonary problems, oral cavity, and thyroid problems. And these guidelines are increasingly being used for all the transplant teams, but as I said, not only the transplant team should know them, every doctor should know them. And finally, I would talk about gonadal damage and infertility after stem cell transplants. Alkylating agents and radiotherapy are very good gonadotoxic. Infertility rate after transplant in children and IAS is very high, is 75%, 83% in females, and 69% in males. It depends on sex, age at the transplant, agent, and dose. Busulfan, which is a drug that we use almost universally, is very toxic for females, especially for ladies, girls older than 13 years. TBI, total body radiation, is very toxic too, but is very good for ALL disease, and we still use it, and we probably will be using it for a long time. In males, it produces long-term azoospermia, worse if they are older than 13, although testosterone production is usually spare. And in females older than 10, is 100% ovarian damage after TBI. This is also a very recent publication in which you can see how In TBI-used regimens, the azoospermia rate is greater than 80%, whereas busulfan produces almost more than half. And what should we do to preserve fertility? The only thing we can do so far is appropriately inform the patients, because most hematologic neoplasias usually don't give time for fertility preservation maneuvers, except sperm cryopreservation, which is very easy. But the majority of the patients that come to the transplant have already had a lot of chemotherapy before, and when we set them for sperm preservation, they don't have enough sperm to be preserved. So this should be done earlier in the phase of the disease before they come to transplant. Mature oocyte collection and cryopreservation or ovarian tissue cryopreservation has the same problem. When a girl is diagnosed with acute leukemia, we don't have time to do this cryopreservation that will take almost a month. So it's probably impossible. Embryo cryopreservation, which is the maneuver that is most recommended in the literature, is also impossible for acute leukemias or for hematologic neoplasias, particularly because these patients usually are too young to have a partner already. Menstrual control is needed during thrombocytopenic periods, and after the transplants, the female should have hormone level studies at 12 months, and very importantly, they have to have early hormonal substitute therapy, which is a problem that we have with all the gynecologists and obstetricians in Spain, at least. I sent a 22-year-old girl to the gynecologist, telling them to start hormonal therapy, and the majority of them think that they will recover. And even if I say they're not going to recover because I gave them TBI and this is impossible to be recovered, they won't give hormonal substitute therapy so easily. We have to write in forms, we have to talk with them personally, and it takes a long time to do this. This therapy should be combined with estrogens and progesterone so that they have their normal menstrual period and they preserve their organs for future maneuvers of fertility and assisted reproduction techniques that are being better and better every day. Regarding males, what I said, a spermiogram after 12 months should be done yearly. The majority of them won't recover their sperm counts, and they should cryopreserve their sperm before the transplant. So with this, I finish. My conclusions are, the doctor's point of view is that a stem cell cures many little diseases. AYAs are excellent patients for stem cell transplant, particularly for adult hematologists. We love these young patients. They're wonderful, they're physically resistant, they're psychologically lively and joyful, they become our friends very easily. Every indicated stem cell transplant should be done because it can be done normally. There's always a donor, as I said, we can use any donor, HLA identical siblings, unrelated, haploidentical, any donor. But during the procedure, they have very special needs, as is being talked in this meeting very frequently, carefully. We should be very careful. We should be very concerned about their problems. We will have to continue to inform them. We have to be very tolerant and very patient about them. And late effects are inevitable for cure so far. We are working on it. We are trying to decrease these late effects, but don't forget, you have a lethal disease. So you have to go through this. What should we do? We will do with time. Chronic GVHD may profoundly affect body image, frequently physical sequelae. We have to try to minimize this. Infertility preservation is very difficult. Reversal should be developed farther than it is now. And second, malignancies are too much to pay. But so far, we can do very little. And that's all. Thank you very much. I'll be glad to answer any questions. That's an excellent question, Isabel. In fact, because when you're trying to review these types of things, you get into one publication, another publication, and I got to the second malignancy at the end of the talk, let us say. And then when I found all this overwhelming evidence that TBI is horrible, then I tried to go backwards, and there are still a lot of publications, and they're not very old, that demonstrate that TBI is best to cure ALL. So I don't know about the answer of that. In fact, we are, for example, in the hospital, we had the radiotherapy, ¿cómo se llama? El acelerador lineal. The lineal accelerator was changed lately, and we insisted that we wanted TBI again. And now I'm very worried about TBI, but there's nothing I can do so far because we are still using TBI for lymphoblastic leukemia. Any more questions? Okay, thank you very much.